Now I will request Dr. Puneet Dhar, Chief of GI Surgery at Amrita Institute, Kochi, to discuss about open surgery in rectal cancer and its advantages over laparoscopic surgery.
Wow, wasn't that wonderful how Aman was trying to hard sell laparoscopy, as if we don't have enough of hard sell for that, isn't it? So what are the issues when we need to discuss whether it should be lap or open? First issue is it possible to do a lap LAR? The second, does lap LAR offer any benefits? Are there any technical challenges? Is a high quality lap LAR generalizable through training, or will it be left only to super specialists? So let's address these. What are the putative, what are the advantages which are touted? Cosmesis, less pain, early recovery, reduced length of stay, magnification. I agree with magnification, but I'm a little worried that despite the magnification, where you see the thoracic duct or the presacral nerves, there's actually either the same or no improvement, or in this case even a worse outcome in terms of sexual or urinary function. But at least for the diagnostic laparoscopy part, I agree that you might pick up metastasis and might render a non-therapeutic surgery. Is there a lot of hiss? And the other definite advantage is the ability to mobilize a splenic flexure, because in open surgery you end up giving a very high extension to the midline laparotomy to mobilize the splenic flexure. I grant you these two, absolutely. All the other benefits, it's very, very interesting to know what is the fast tracking got to do with it. Benji gave an excellent talk on this and how the benefits are there. And it's the same whether it's lap or open. The year that the first laparoscopic cholecystectomy was done, Adarsh, who's in the front row, had presented a paper on, written a paper on tubeless, drainless, short stay cholecystectomy. And the patients actually went back a day earlier than all the lap choles for the next 3 years at least. So it's the fast tracking which is important. But do I have evidence for that? Of course I do. There's an excellent trial which is I've never been alluded to frequently. This is randomized, blinded, where the patient and the observer are blinded to whether it's an open or a lap procedure. And guess what? And they're run through fast tracking. And guess what? There's no difference. So it's the fast tracking bit of laparoscopy. I'm grateful to laparoscopy for ushering in the era of enhanced recovery after surgery. But probably, apart from minor immunological benefits, there's probably not much of a difference in all those things that we keep harping about. So are there any potential disadvantages? If there are no advantages, maybe we should still try it because it's exciting video games for the surgeon at the expense of the patient. Well, increased operating times for a third world country like ours, definitely increased ancillary costs. By the time Covidian and J&J bring all this stuff to us, we have a lot more VATs and a whole lot of tariffs added onto it. You need a high volume center and good training in both minimally invasive surgery as well as pelvic surgery as a prerequisite. There's a huge learning curve, as I'll just come to that. In many tumors, which we see very frequently in India, bulky tumors, narrow pelvis, obesity in males, indeed after surgery or radiation, it's very difficult to go beyond. The dissection can be very difficult. I've heard of lots of times people saying that we had to open up this because it was difficult. I've never heard anybody say that this is too difficult to open. Can we close it up and do it laparoscopically if it's actually simpler? There is a worry about increased port site metastasis, and I think there's been such a hard sell that this has been brushed under the carpet, and I'm sure we're going to see more of this. But a lot of things have been done, like protecting the wound and all for this. There's definitely increased sexual dysfunction, and there could be a technical difficulty in transecting a very low beyond the tumor, the anorectum or the rectum. In India, my worries are it's a there's no training, it's either poor, it's self-trained or one-day workshop training. There's no credentialing, no mentoring, no standardization. So we blindly use the principles and the evidence from there and use it here. No adverse effect reporting mechanism. How many of us would admit that a patient with laparoscopic incisional hernia has died? How many would report that a urethra has been injured in a lap LAR? How many indeed would even admit that a lap hernia had an infection? It's all anesthetic complications, isn't it? There's a hard sell from industry to modernize. This symposium is one such example. This from the corporate management, as we are seeing much more drive in the healthcare sector in India for weaning off sales from other places. The cost. How many do we actually dispose of the instruments? How many of us, we all show it, but how many of us consistently use a wound protector in every case of hand on heart? How many you actually do that? How many do we see all those small T1 tumors which we read about in all these trials? So do I have any evidence? Of course I have. I'm sure you didn't hear a single trial from Aman showing the benefit. This is the only trial on which included rectal cancer, and we have long-term data on that. And what does this show? It shows a higher rate of rectal circumferential margin positivity with lap 2 times. The lap to open conversion rate was high, 32%. This has been criticized, but ladies and gentlemen, that's the real world. In this converted cohort, there was a much higher mortality rate of 13%. Where you would expect the magnification to actually improve things, the male sexual and erectile dysfunction was more impaired in the lap group versus the open group. And as Aman has repeatedly said, no difference in overall survival, defensive survival, etc., etc., etc. So this has been criticized that many of these surgeons, the requirement was 20. How many of us in the hall, the chairman is exempted from answering, have done 50 lap low anterior resections? So do we mean 50 into 600, 30,000 before we reach that critical mass? I leave the math to you. If there is a single iota of benefit, I would still say that. But that may not be progress. The COREAN trial, as Aman has said already, was a much more sensible, much better thought out. And what did it show? Blood loss was low by 17.5 milliliter average. And this was significant. But he omitted to mention there was a longer operating time for lap, which was also highly significant. And all other parameters were equivalent. So this reminds me of George Orwell's Animal Farm, where the animals overthrow the human farm. I don't know if you remember this, where each and every, in the name of progress, everything is distorted. All animals are equal, some are more equal than others. The last one, if you remember that, they're against the humans. 4 legs are good, 2 legs are better. So the robot should be even better. But this year itself, the FDA has, I think all of you know about the strictures it's applied on the Da Vinci system. So why is every trial designed to show non-inferiority? Is there an inferiority complex? Why doesn't anyone design a trial to show superiority of lap LAR if it is so good? Till then, even if it's same, why do we need to change? Is it because we want to play video games? Is it really cost effective, especially for our country? Even with the prolonged torturing of the economic data that we do in all these papers? It may be suitable for this hospital, but are you sure it's suitable for this one? Training. I mean, all these papers have shown that you need a lot of special high-intensity training. And anyone who wants to do lap, low anterior resection, has to take a lot of special high-intensity training. Otherwise, he may land up in the Departmental Education Evaluation Program, that's deep SHIT. So basic question is not lap versus open surgery. It's how to train a surgeon in colorectal cancer surgery to achieve better results in terms of morbidity, mortality, 5-year survival, and patient benefit. So let's have a relook at the issues. Is it possible to do LAP LAR? Of course it is. Does LAP LAR offer any benefits? What are the technical challenges? Plenty. Is high quality LAP LAR generalizable through training, or will it be a super specialty based thing only? I think every trial says that it has to be high volume centers, specialty training in both MIS and pelvic surgery. I think one of the largest centers for colorectal surgery, Basingstoke, this gentleman from there gave a lovely thing. Rectal cancer surgery, is the possible sensible? Of course it's possible, but is it sensible? Is return to oral 0.6 days or go home 1.8 days of any importance to a guy who gets his cancer once in a lifetime, if there's even the slightest iota of an increase in any chance of a compromise? I leave it to you to debate whether I'm an outdated dinosaur ready for extinction or a wise owl who's been there, done that. I thank you for a patient listening.